Welcome to the NP POW Videocast, a space where we will talk to nurse practitioner experts who will share their POWs, or pearls of wisdom, on the latest in advancements on an array of healthcare topics. I'm your host, Dr. Julia Rogers, a certified nurse practitioner, and today we are honored to have Dr. Alycia Bischof with us to discuss pediatrics. Thanks for being here, Dr. Bischof.
Thank you so much for inviting me.
So first, can you just tell us a little bit about yourself, your work in pediatrics, and then the topic that you're going to discuss with us today?
Sure, I'd love to. I am a pediatric nurse practitioner. I have been practicing in private practice now for close to 30 years. In addition to that, I also teach at the University of Pennsylvania School of Nursing, which I've been there for about 10 years. There I teach the physical assessment course to graduate students. In addition, I'm certainly teaching in the pediatric primary care program, where I do an array of different lectures to them. I also am the coding and billing lecturer for the university as well too. So I do a lot of coding and billing talks to the students there as well too.
Very busy. You're a very busy woman. What are you going to talk about today?
So today I'm going to talk about RSV, or respiratory syncytial virus.
So I know that RSV can be really scary for parents, caregivers, as well as even siblings and the children themselves. So I can't wait to hear the information that you can provide for us today. So let's get started with just the very basics. So what is RSV and who can get RSV?
So RSV is a virus, and it mainly affects the respiratory tract. Usually we think about it as a lower respiratory tract infection, but it also has been known to cause other viruses in the respiratory tract, such as croup or sinus infections. And it's really common, and it's highly contagious. In fact, it can even live on surfaces for several hours. So that makes it even more contagious, because we're not even aware that the virus is still living on surfaces that are in the room that we're in. And it's the leading cause of hospitalization for babies under a year old.
So why is it so dangerous for young infants?
Well, it's dangerous mostly for two reasons. One is because they have a pretty immature immune system still. They've never been exposed to this virus yet, so they really don't have the antibodies to fight it off. That's number one. And then the second reason is because it is mostly a respiratory illness. It affects the nose, so there's a lot of secretions in the nose, and babies are obligate nose breathers. So if their nose is clogged up, they really can't breathe very well. So it really affects their breathing, and it makes it hard for them to breathe.
One thing that I've always thought about is, does RSV come around during a season? So I live in a state where it's winter, and so of course we have the tendency to see more RSV in the winter. But for, say, someone that's living in Arizona, do you still see it in winter months? So is there a specific time of the year?
So it's an interesting question. If you asked me pre-COVID, I would have had one answer, and now it's a little bit of a different answer. But RSV, typically we think about it as fall to early spring. So I live in the Northeast. We typically see it between the months of, say, like October and March. And certainly if you live in different geographic areas, it may be different in, say, Florida and in Alaska. The seasons might be a little bit different. However, in the last couple of years, we've been seeing it 12 months a year. We've been seeing it in June, which kind of was unheard of before, but no time of year anymore can we really discount the fact that it could possibly be RSV, which is causing the illness. Although I think it's primarily a fall winter virus, but like anything goes these days. So I really, if the shoe fits, I would still be screening and considering the fact that it could actually be RSV.
Well, and time has changed, and even the population, because now we see it definitely in more adults as well. So thanks for that.
Exactly.
Can you tell us a little bit about the symptoms? What's the initial presenting symptom, and then maybe how the symptoms progress?
So interestingly enough, RSV presents in many people just as a cold. We see it in babies, as you alluded to. We're seeing it in older adults, but actually anybody can come down with RSV. But the reason it isn't labeled or brought much attention to it in the other population is because it really just looks like a cold. So with mild symptoms. So you may see congestion, runny nose. That's probably the biggest thing that we'll see with it. A dry cough. May or may not have a fever, and if you do have a fever, it's awfully a low-grade fever to start out with. You may be seeing a sore throat, some sneezing, maybe even a headache, but that's your typical mild virus of RSV. And even in the babies who might get a more serious illness, they often start out with just really mild symptoms for like the first 4 or 5 days, and then it might actually rev up and become a more serious virus.
It sounds like a lot of the symptoms have crossover to other viruses like influenza and COVID. So how can we distinguish it from the other viruses that are out there at the same time of year?
Exactly, right? Or, there's a lot of different viruses that all affect the respiratory tract, and it can actually be tricky. Some things that we can look at is, for instance, if we look at flu often comes on real suddenly, and often the biggest complaint that I see with flu is they were feeling fine one day, and then all of a sudden they get high fevers, chills, body aches, and that kind of distinguishes flu from other illnesses, are those body aches and the chills and the fevers. With COVID-19, well, COVID-19 changes every time that it mutates again. So, it's presenting itself in very different ways. It often it comes on more slower than flu symptoms do, and it often builds gradually over time, the symptoms with it. Certainly, if you have a loss of taste or smell, that's going to lead itself more to COVID than to the other viruses. But even that, we're not seeing so much with COVID anymore. But I would say probably the biggest thing is that it's a slower progression. You also have GI symptoms with COVID as well, such as like diarrhea, nausea, vomiting, which you typically are not going to see with RSV. Now, when we talk about, what's different about RSV than the other viruses, I'd say wheezing. You often will see wheezing in especially the infants, but typically you're not going to see wheezing with flu or with COVID.
That's some really great differentiation. So I appreciate that. It kind of separated it definitely for me within my brain. Is there any diagnostic tests that you could do that would kind of tease it out? And then would the provider know when to order those tests?
Sure, exactly. So many times we don't test for RSV because, like I said, it's a typical cold. So they might call you on the phone, or they might come into the office with slight fever or cough or runny nose, and you just give them the standard cold treatment. But then if they're coming into the office and they seem a little bit sicker, or they're having difficulties breathing, or the cough is like a significant cough, and that's really the reason they're bringing them in, well, at that point, we might want to actually test them to find out what's the cause of this. RSV it's become easier to test because there are tests that we can actually run in the office. So it's a nasal swab. Typically, we'll be running the COVID, the flu, and the RSV all at the same time. If it seems that all those symptoms were kind of teasing them out there, but it's a nasal swab, and like within 10 to 15 minutes, we can have results on all 3 of those illnesses back, positive or negative, so we can actually know what we're treating.
That's great. And especially if you're treating or at least getting all 3 swabs, then you can tease out what it is. Can RSV be treated at home by parents, or are most children hospitalized with it?
Actually, most children are treated at home. So that's the key. The mainstay of treatment actually is going to be at home because it's symptomatic treatment. So if they're having a hard time with the secretions in their nose, typically we're going to be using saline spray in the nose, bulb suction out the nose. I tell parents, get your humidifiers out. Get the humidifiers going in the room. If you don't have a humidifier, steam up the bathroom, bring them in the shower. Let that humidity in the bathroom kind of loosen up all those secretions as well, too. And then keeping them hydrated is really important. So forcing fluids. Sometimes babies don't want to eat so much, but we got to at least make sure that we're getting fluids into them. Of course, the younger babies are only probably going to be drinking either formula or breast milk, but we just got to make sure that we're encouraging that they're getting hydrated. And then, of course, fever control. So in the under 6 months population, acetaminophen would be the drug of choice. If they're older than 6 months, we could add ibuprofen or acetaminophen, either one, so just to treat the fever and any kind of irritability or aches or pains that they may be suffering with as well.
When should parents be concerned and actually reach out to the provider or take the child to the hospital, to the emergency department?
Yeah, that's a great question. So again, RSV affects breathing. So if the baby's having a hard time breathing, that's going to be a reason, depending on how serious the difficulty is. I'm either going to want to see them in the office, or if the parents are saying they're gasping for air, if I can hear them over the phone gasping for air, I'm sending them right to the emergency room at that point. But if they're calling and they're saying they're coughing a lot, they're irritable, they're not eating as well, those babies, I'll probably bring them into the office first, because maybe just by me evaluating them, I can give the parents some techniques of how to take care of them at home. But if the baby's really, they come into the office, they're having a hard time breathing, I'm seeing retractions, I'm seeing nasal flaring going on, I get a history about hydration, and I find out that not only is the baby not drinking well, but they're not wetting diapers. And the baby's like really irritable, or on the reverse side, that they passed the irritability stage and now they're just really more lethargic. Those babies, and I'll probably get a pulse ox on them as well too, if we're seeing the pulse ox drop, those babies are going to be admitted to the hospital.
Now, I know that that also is a very scary time for parents, telling them that they need to take their child to the hospital. So I'm just wondering, what kind of advice could you give to other nurse practitioners to educate the parents on what kind of treatment would be happening in the hospital that wouldn't be done at home?
Right. And absolutely, before I send a parent to the hospital, I always try to give them expectations of what to expect while they're there. So there are no medications that are given to babies with RSV. Again, it's supportive care. So once the supportive care, we can't do it at home anymore, we're sending them to the hospital. First line is most likely going to be humidity. Maybe it's going to be a mist tent, maybe just increased suctioning. Certainly you have the wall suctioning in the hospitals where parents don't have at home. So that's something that they could do in the hospital that they can't do at home. For hydration, they could do IV fluids to keep the babies hydrated. They also could put an NG tube down, and I explained to parents what that's going to look like. So they could do feedings for the baby if they really can't take any foods by mouth right now. Certainly, if for a more severe case where we're still having a hard time with breathing, those babies may actually require oxygen. And depending upon how much oxygen they need, how old the baby is, that could be nasal cannula, it could be a face mask. And in more severe cases, sometimes those babies are even intubated.
Well, certainly the more education that we can give parents, the anxiety level goes down. So
Absolutely.
Great advice on what to tell them. One of the questions that I have is, how can we prevent RSV?
Well, first of all, as I said previously, the RSV virus can live for many hours on surfaces in the house. So first, it's going to be like your standard cleaning. How do you keep your surroundings clean? So I tell them, wipe all the surfaces down, get those Lysol wipes, do all the handles in the house, because we don't realize sometimes that we're touching the handles. Hand washing, make sure they're doing good hand washing. Limit exposure to crowded areas, because again, it's so common, it's so prevalent in society. We want to keep them away from the virus in the first place. Also want to limit smoke exposure, because smoke exposure has been shown to be a risk factor for contracting RSV as well too. So first we want to look at the environment and how can we control the environment as best we can. And up until a year ago, that was pretty much all that we really had to prevent RSV. Outside of there was one medication. It's actually a monoclonal antibody that's been around since the 1990s. And forgive me, because the pronunciation of these words is much harder than than sometimes the treatment. But palivizumab, which is also known as Synagist, has been around since the 1990s. That can be given to a child, an infant, once a month. It's an IM shot, and it's given once a month in the thigh. So, we would think, well, that's great if we have this protection out there, because we're actually giving passive immunity. We're giving the antibodies to these infants. Why not give it to everyone, right? The problem is that it's very expensive. It's about $2,000 a dose. And we're talking about monthly doses. So you're talking about 5-6 doses. So you do the math, it's probably about 10 grand just to treat one infant to help prevent RSV. We're not, we're not treating it. This is a prevention. So because of that, that treatment it's limited to only the high risk babies. So high risk meaning like severe, like premature babies, talking like 24, 28 weekers, those with congenital heart disease, chronic lung disease, neuromuscular disorders as well, because those infants may have a hard time coughing up the secretions if they were to become infected. So up until now, that has been the only prevention that we've actually had to help these babies. However, this.
Oh.
Gab, are you gonna say something else?
Oh no, finish what you were saying and then
all right. But however, this season we actually have a new preventative treatment on the market, and it's called Nursevibid, and also the trade name for that is Beyfortus. So with this, it's also again, it's a monoclonal antibody. So it's going to provide passive immunity to babies to protect them against RSV. It's cheaper. It's about $450 a dose, I believe. More insurances are covering it. Certainly, it's easier to get than the other treatment out there, or the other prevention. This is given once in the first 8 months of life at the beginning of the RSV season, and it can actually last for 5 months. So babies are getting one injection. And then the hope is that they're going to provide protection during their first RSV season, which is when they're the smallest and there's the most concern. And then it's also been indicated for babies that are at a higher risk that those babies can actually go ahead and get a second dose, their second RSV season, to give them 2 years of protection.
Well, that's really nice. I think, they've grown over time, the monoclonal antibodies, and we just happen to hear more about them because of COVID, but they've been around, as you said, for a long time.
Right.
One of the things that you mentioned that I rudely interrupted you, so I apologize for that, was that you talked about hand washing. And I know when COVID came along, I felt like I didn't realize how much I was touching my face, because the mask was there. And I was like, wow, people do touch their face a lot more than they think. But children are a little bit harder to kind of guide. So I'm just wondering from, a parent standpoint, how do you get your child to wash their hands, to not, wipe their nose? Do you have any tidbits of information as treating for pediatrics over a long period of time? What do you do to get them to kind of follow those rules?
Well, hand sanitizer has really been a mainstay. And I heard one teacher actually said it's her germ gel. And she tells all the kids when they come into the classroom, they have to use the germ gel. I think kids are just, they're going to follow whatever example is set for them. I know we can go back to the same exact conversation when COVID hit and people were saying, how are you ever going to have kids wear masks? Well, I've seen kids wear masks a lot better than adults wear masks and over their nose appropriately, right? So I think it's just the way that we train them and what's expected, right? We just bring them to the sink. They know after they use the bathroom, they go right to the sink and wash their hands. Before they eat, they should go right to the sink and wash their hands again. And there's hand wipes. You can even have them in diaper bags or in moms or dads in whatever bags that they might be carrying around with the kids. Just get into the habit of constantly wiping their hands, washing their hands. And I think it's just, becomes a habit, right?
Right. And I do think example goes a long way. Now, I know that we now have a vaccine, so I was wondering if you can tell us a little more about that.
So the vaccines are only approved for adults. Okay, so there's 2 new vaccines, and so nice that the generic names for the vaccine are RSV pre-F3 and RSV pre-F. So it makes it a lot easier to say them, right? So there's 2 different vaccines on the market. Like I said, they're both approved for age 60 and older. The caveat to that is that the RSV pre-F, is actually also approved for pregnant people. So the recommendation right now is that between 32 and 36 weeks of the pregnancy, that vaccine actually should be given. And then if it's given 2 weeks, at least 2 weeks prior to the delivery, then the baby actually is going to get some protection against RSV from that as well too. And the indication is that if the vaccine was given, then the monoclonal antibody should not be given because the baby will have the benefit from the vaccine that was given.
Wow, we really have made a lot of progress in this for RSV, certainly over the years. The next thing I want to ask is, when should a patient return for follow-up? So is it different if the parent was treating them at home versus if the child was in the hospital and being discharged?
Oh, absolutely. So if it was a mild case and we just happened to test them, we found out when they came in with cold symptoms, and the medical assistants kind of get really anxious and they test everybody anymore. I feel like, I'm trying to tell them not to. But if the child is really not that ill when they come in, then there's really no reason for follow-up unless the parent wants it, or they're unsure, they're uncomfortable dealing with the child at home, or school notes, right? A lot of times we need to see them back because the schools are requiring school notes to bring them back. For those babies that are hospitalized, those we want to see them back within a week of being discharged from the hospital. Usually within 48 hours, generally we're seeing them back in the office to make sure that they haven't relapsed, to make sure that the parents are comfortable taking care of them. Because, one thing is they might be able to breathe better, but that cough lingers for a while. And sometimes it makes parents really nervous seeing that these babies are still coughing. They've been discharged from the hospital. They're telling the parents that they're better, but yet, 2 weeks later, the baby's still coughing. So a lot of times I'm going to bring them back into the office. I'm going to reassure them that coughing is normal. As long as we're seeing the coughing getting less, then we're heading in the right direction. If the coughing increases again and the baby's in distress again, that's another story, right? But as long as we're seeing slight improvements as the days go on, I reassure parents that the child is indeed getting better.
Amazing. So what other educational topics could you provide or cover with the patient or caregiver or family members that would help them understand RSV? Is there anything that you haven't told us about educational topics?
Well, one thing is that I always like to make sure that I stress is treatment, because actually years ago the treatment guidelines for RSV have changed. And when I first started practicing, like I said earlier, one of the things that we see with RSV that we don't see with flu is wheezing. So, in our minds, I think it's kind of been ingrained. Wheezing, we think, how do we treat wheezing? We usually see wheezing with asthma and we give albuterol, right? Or we give steroids. And steroids and albuterol are not the treatment of choice. Those guidelines have changed. And even people that I work with in my office, I still see them even giving albuterol treatments. Oh, well, what if it's asthma that they're coming in with? I'm like, but doesn't look like asthma. You don't see, fevers and all this congestion with asthma. So I think that's a big thing really, is making sure that people are educated what the new guidelines are, or the newer, I mean, they've been around for several years now, that albuterol is not the treatment of choice for RSV, and neither are steroids. I even see people coming in, like they may have gone to the ER and they come in and say, oh, the ER gave me this medication. I'm like, I like cringe and thinking that's not, not the appropriate medication. So what I find myself doing is, it's education, right? Because what makes sense. And I try to educate my families that, the reason albuterol works well in asthma is because it's the airway goes into spasm, or it shrinks down. And the albuterol is really good at releasing that spasm and opening up the airway again. With RSV, there is no spasm of the airway. It's just clogged with mucus. So I don't care how much albuterol I give, I'm not going to be able to open up that airway more because that mucus is still clogged in there. So I try to explain that to them, so they understand why they could be giving, albuterol for wheezing and asthma, but not for RSV.
That really is great advice. I work in pulmonary, and because I see a lot of COPD patients, of course, wheezing, that's exactly what I would be thinking is steroids and albuterol. So thanks for the clarification.
Right, right.
In the last few minutes, I was wondering if you could provide one or two pearls of wisdom, or what we here at the Nurse Practitioner Videocast call POWs, specifically for providers on RSV.
Well, I think, again, going back to the albuterol, I think that's important for the providers to know as well, not just the patients. Other things about them is I just want to make sure that they all realize that the different treatments that are out there, especially as treatments are changing, make sure that they're aware of the monoclonal antibodies, asking the parents if the RSV vaccine actually was given during the pregnancy. Those are some important things that I can tell you. I was just talking to the providers at my office, and I said, before we give it, make sure that we ask, was the parent vaccinated? And they're saying, oh, I didn't even know that was the possibility. So, with these changing guidelines, that's really important to be making sure that we're asking those questions and that we're treating our babies in the correct way.
Well, such wonderful advice provided today, Dr. Bischof. So thank you again for sharing your time and your knowledge and your POWs with all of us with the NP POW Videocast.
Well, thank you so much for having me.
So I want to thank also all of our viewers and hope that you come back to hear more pearls of wisdom from our NP experts in the future. And until then, this is Julia Rogers wishing you joy today and every day.